we begin with the next session. We are already late. I invite the Chairperson Dr. K.P. Kudlu, Co-Chairperson Dr. Krishna Prasad R, Dr. Amit Shah, Dr. Sujata Mohan, Dr. Deepak Mishra. Uh, Till the chairpersons are arriving, we should not waste time. So Dr. Amit Porwal, Member Scientific Committee, I open up the session. So the first talk will be given by me. Then we'll have Dr. Mohan on the other podium. Please connect his laptop on the other podium. So after Dr. Mohan, we'll have Dr. Pradeep Mohanta. This side, yeah. So I'm going to talk about important pearls for managing mature intumescent cataract. I've got no financial disclosures. So we all know that intumescent cataract, they are swollen, congested, there's hydration of the lens matter, there's an increased intraventricular pressure. So the problem faced while doing cataract surgery is difficulty in visualizing the anterior capsule. The capsule is stretched, it is more convex. So because of this convexity, there's a peripheral split of the anterior capsule after the first puncture. There's liberation of the liquefied cortex, which may obscure the view, and there is peripheral extension of this capsular axis, giving rise to the Argentinian flag sign, which is a more direct line any cataract surgeon can face while doing phaco surgery or an SIC surgery. So CCC is an essential step for successful phaco surgery, and performing CCC is a wide intumescent cataract is a great challenge to all the phaco surgeons. So what is described in literature to overcome this Argentine flag sign is doing a mini rhexis. Now what is a mini rhexis? Doing a small rhexis. You can do a snail pattern or onion ring pattern rhexis, wherein you peel the anterior capsule like a onion ring pattern and go on peeling off to have a rhexis from small to a desired size and shape. You can also make a heart-shaped rhexis, and there's another technique called pancho rhexis, which is devised by our own colleague Dr. Mohan Rajan. But what I recommend now is this. You can see at this video, a lot of important steps will be played in this. So this is a swollen intumescent mature cataract. Staining of the anterior capsule with trypan blue is very, very important. Now, why this is important? Because this anterior capsule is very elastic. So the moment you touch this anterior capsule with trypan blue, the tensile strength or the elasticity is lost. It becomes a bit more, you get more control on the capsular axis when you're performing. Now, this is a very important step. You can see this is a 24 gauge needle mounted on a 2 cc syringe. You pierce the anterior capsule at the center. Just remain stable there without any tremors. Aspirate the loose cortex or the liquefied cortex as much as possible. I have done this titration with 1 ml, 2 ml and 5 ml. 2 ml is the syringe with a 24 gauge needle, which gives adequate suction. You can aspirate and then you have this cut a bit. Then reform the anterior chamber. Sodium hyaluronate is the best is the best viscoelastic which you can use. Try to aim for a smaller rhexis. Begin always with a smaller rhexis initially. And once you have started up with the smaller rhexis, you will know whether the rhexis is extending or no. So if you think that the rhexis is not extending, you have started with the small rhexis. Now what I'm going to do is I've reached the starting point. Now I'm going beyond the starting point, and this is the snail pattern or the onion ring pattern of the rhexis. Dr. Krishna Prasad, please, chairperson. So you can see now this is called the snail pattern rhexis or the peeling of the onion rhexis. So initially a small rhexis in a mature intumescent cataract after the intraventricular decompression gives a better control of performing a mini rhexis, a double rhexis or a snail pattern rhexis. So you can see in this the rhexis is being enlarged in a snail pattern or the onion ring pattern. I'm getting enough control. The small tears which you have to give, you should always make sure that the flap is flat and the AC is adequately maintained with sodium hyaluronate. You should not over deepen it. You should not make it too tight. So you should be adequately filled. So intraventricular decompression is very important. Now if suppose your rhexis is small, you are not satisfied with the overlap of the anterior capsule over the optic, you can always refashion this rhexis after emulsifying the cataract, injecting the IOL. Now you see my rhexis was decentered superiorly. So I given a small tangential nick. This is very, very important. We should always give a tangential nick and should never give a vertical nick, because if you give a perpendicular or a vertical nick, the chances of capsular tear or the extension to the periphery is quite high. So give a tangential nick. With the help of a micro rhexis forceps, a 21 gauge micro rhexis forceps, you can refashion this shape of the rhexis and the size of the rhexis to the desired size and shape what you want. So to do this, you should be well prepared. You should do with the right hand as well as the left hand. We should be used to the needle and the capsular axis forceps. Again, I'm showing one more video. This is a large intumescent, well-dilated cataract. You see, I've entered the anterior capsule in the center with the 24 gauge needle, and you can see the concavity of the anterior capsule which is occurring as I'm sucking the liquefied cortex. So this is very, very important. Be stable there. So the central 5 millimeter almost you get, it's a bit concave. So you know that the capsule is flat there. Reform the anterior chamber. Make this capsule flat. And now proceed with the rexes. As I told you, you should be comfortable with the right hand as well as the left hand. So usually I look at where is the nick, capsular nick which is going. So in this case, I thought with my left hand, I'll start with the rexes so I get a better control. In this, I'm not doing a snail pattern rexes because I've got enough decompression in the central 5 millimeter zone. So if you see, the central 5 millimeter zone is flat or a bit concave, but beyond that there is a convexity. So now I'm getting a good control. I'm going with on the right side port. So that what I'm trying to tell you is this type of situations you should be well versed to use both the right hand as well as the left hand. You should have a capsulotomy needle as well as a micro rexis and a micro 1/2 forceps, which is very, very important. So you can see an adequate size of the rexis is achieved without any capsular extension. Another technique of this intraventricular decompression to manage this intumescent cataract is anterior yak capsulotomy. You saw a shot of entry, one shot of 1.2 millijoule of yak was given in the center of the anterior capsule, and there's a gush of liquefied cortex. It goes on falling, for the liquefied cortex goes on falling like a Niagara fall. You can see that. You do this procedure in the OPD, shift the patient to the OR, and do under topical or block, whatever you're comfortable with. So by the time you shift the patient to the OR, you already know that this intraventricular decompression has occurred. There's a stellate star pattern opening when you give this anterior capsulotomy shot. And you can use a rexis forceps or a needle, whichever you're comfortable with, and start with your rexis. Again, follow the dictum, a mini rexis or a snail pattern rexis, or you can do a double rexis. So anterior yak capsulotomy plays a very, very important role in handling this mature intumescent cataract. You can see again, I've given one shot, and see how the liquefied cortex goes. See, the shot is given and the liquefied cortex goes on falling down like a Niagara fall. Okay. So this is another way of decompressing the intraventricular pressure. So this is what you see when you give a anterior yak capsulotomy shot. This is a 1.2 millijoule single shot which is given. You can see a stellate pattern or the star pattern of the anterior capsular rupture, which you can see. We did a OCT pre-yak and post-yak, and you can notice that there's an increase in the AC depth after this yak capsulotomy. This was published in Asia Pacific Journal of Ophthalmology last year, and we also presented the various decompression techniques and various capsulorhexis type patterns with the mature intumescent cataract, and we presented in last year in AIOC and won the best physical poster for this particular technique. So what the most important pearl for managing mature intumescent cataract is intralenticular decompression. Whatever happens, you have to decompress these lenses. So how can you do it? ND ag laser anterior capsulotomy, or a slow and a guarded decompression with the help of a 24 gauge needle mounted on a 2cc syringe. So this is the most important pearl in managing mature intumescent cataract. And this is my last slide. I request all of you all to please support and give your blessings to me for my candidature for member scientific committee in the coming AIS elections. Thank you.
That was a very good compilation, Dr. Amit. According to you, do you like to hit both two birds in the same shot, like want to get the right size of the rexis as well as get the rexis, or you just want to have a rexis, complete the case, and then refashion the size?
Usually what I prefer is just do a small rexis first, because most of the time these intumescent cataracts are soft cataracts. So you can manage with the soft rexis, small rexis. So if it is an intumescent cataract, I just do a small rexis, emulsify the cataract, inject the IOL, and then I'll refashion because I'll get a better control. Because a lot of times what happens is you have decompressed, the only central 5 millimeter is there. But sometimes that posterior support which is there is not available. So then that time this is a better option.
Yeah, I think that's a good idea. That's a good advice, because many times you would like to probably save time by trying to do a right size in the first situation itself. Maybe it's a good idea to have a rexis and then probably think
Only thing is never try this thing when you are using a PMMA lens, because then chances of capsular rupture by injecting the lens into the bag will be there. So always use a foldable lens, and whatever lens, even if you're foldable, hydrophilic or hydrophobic, if it's a very thick lens, high diopter lens, then even if you have done a small rexis, when you are injecting the lens into the bag, there will be some resistance at the anterior capsular margin if the rexis is too small. So you have to take a call. If it is a normal thickness of the IOL, it's a normal standard IOL powers, you can do a small rexis and inject it through the anterior capsular opening and then refashion with the help of micro rexis or a micro 1/2 forceps.
Thank you, Dr. Porwal. Now I call upon Dr. Bharti Kashyap. Okay, Dr. Mohan next.
Mohan, yeah.
Okay, okay.
Okay. Yeah. But I have to go for the OPL. Shall I start? Main hall, there is a hall A.
Can you give me a mic?
Anyway, good morning, ladies and gentlemen. Let me thank the AOS for this wonderful opportunity. I'm going to give you 7 pearls of how to manage this IFIS, which is becoming a huge problem. So what is the biggest problem in phaco? Is it hard brown cataract, PPC, subluxated, or a pseudo exfoliation? Unfortunately, no. Okay, the biggest problem is the small pupil. Why the small pupil? Because in small pupil, you are not able to see anything, and that is the reason why all the complications can occur because of the small pupil. Now, what happens is alpha-1 blockers are used for benign prostatic hypertrophy. These can, even short-term use can lead to non-reversible iris dilatation function in many patients. And tamsulosin is a commonly used progressive intraoperative wherein the pupil starts coming down on you during surgery and making your life very, very difficult. Iris prolapse, billowing of the iris, the incidence is as high as between 33 and 78%. And as I told you, tamsulosin is a alpha blocker. It relaxes the smooth muscle of the bladder next, so the patient is able to pass the urine much better. And the iris dilator muscle, it works on the iris dilator muscle as well, renders ineffective dilatation drops. And there are also some antihypertensives which can also cause this IFIS, and that's the reason why you see it in not uncommon in women as well. And some of the women also take this alpha ones or the Urimax for many reasons, for urinary incontinence or something like that. So this iris prolapse is very, very typical of this. I can see once you do the hydro, the iris starts coming out of the port, and if you try to push the iris back, it becomes seeing, and the iris will tear. You can see there's another patient with IFIS, wherein the iris is coming out through all the ports, okay, both the side ports, main port as well, making your life very, very difficult, because every time you push the iris becomes small, or the iris will tear. You can produce hydrodialysis. This iris dance, okay, very, very typical of this. This thing is called billowing of the iris, which is very typical of patients on Urimax as well. What are the complications? Iris chafing, you can name the complications, it's all because of small pupil. Iris bleeding, prolapse, hydrodialysis, zonal dialysis, PCR, nucleus drop, difficulty in IOL implantation, prolonged surgical time, and it's going to make, as you can see here, another patient, you can see I'm doing a bimanual phaco long time back. Even before David Chang described this, we didn't know what exactly the problem is. As you can see, there is the iris chafing as well, and the iris starts coming into the port and making your life very, very, again, a PCR and a nucleus drop. So what is the number one protocol? Past or present use of alpha blockers. Go into the history. Many patients don't, many physicians also don't understand. Many ophthalmologists may not understand this thing. So patients, unless you tell them, are you using any drug for passing urine? Okay, prostate means they will not understand, and you need to tell them. And stopping tamsulosin will not help. Atropine some people are using, that also doesn't help. Less than 6 millimeter dilatation is a red alarm for you, because irrespective of density or cataract, this is going to become 2 millimeter or 3 millimeter during the surgery. So I would straight away go in for an iris expansion device, either an iris hook or a Maligan, which we're going to talk about. You can use intracameral phenocaine plus, intracameral epinephrine. All these combinations are available, which is there. Many companies, Entod is making this phenocaine plus, the Sunways is making the T plus, which is a preservative-free, a combination of tropicamide, phenylephrine, and propracaine as well. Again, well-constructed corneal incision. What I do is I try to do the catalyst or the femtocataract for these patients, because I'm able to get a truly triplanar incision. But if you're going to do a manual incision, go for an anterior incision, longer incision, low threshold to suture. Calibrated side port incisions are described by Rohit and Tushya Om Prakash of Amritsar. You can see here the incision which I made with this thing is a very typically, if it's going to be too long, it's going to make your life difficult. If it's going to be too short, definitely you are adding fuel to the flame in a patient with the IFIS, because that's going to come up. So you can see here again the manual incisions. What I'm considering is constructed corneal incision, both main port and side port. Don't take the side port for granted, because the side port also needs to be a little longer incision and self-seating as well. You can see how long I'm going into the, starting a little anterior. Then normally I start a little posterior in the posterior limbus or the limbal vascular arcade. Here I start a little anterior and go anterior, so making sure that the iris does not come. Again, a strict no to HPMC. Okay, in HPMC makes the pupil a little more hypotonic and IFIS can worsen. I would suggest they use go in for Hyalon or even Viscoat for these patients and disperse a combination of the Viscoat and the thing or the soft shell technique described by Steve Arshinoff. You can see I'm putting Viscoat to protect the endothelium underneath. I'm putting the Hyalon. This will make sure that the iris is pushed back, and even if the, see, don't think that this pupil is well dilated and you will not be. This patient is on tamsulosin. This pupil is going to definitely come down, and making sure that in the beginning itself you do that. Don't do an aggressive hydrodissection. You have to be very careful. Again, trypan blue rexis, because even it's not a major cataract, do a trypan blue because rexis, because you know exactly where your rexis margin is. If you don't have trypan blue, you do not know. If the pupil comes down on you, for example, this pupil is about 5-6 millimeter, but if it's going to come down on you, then you know exactly where your rexis margin is. So again, you can see here, I'll quickly finish off. Even if it's a well dilated pupil, I do a trypan blue rexis. Low fluidic heights, making sure that the bottle height is 80 centimeters, the vacuum is less. Normally I use about 400, 500, and the AFR is also, normally I use about 40, 50, but I use only 25. So again, switch off the irrigation when you come out of the eye. This is not, you should not do in an IFIS patient. Switch off the irrigation, or switch off the irrigation when you go in or come out of the eye. Iris retractors, iris rings, I don't have to mention right in the beginning of the surgery, because halfway through the surgery, after putting the rexis or doing the rexis, the pupil comes down, very difficult to put your iris hooks or a Mulligan ring. Subincisional iris hook can also be done as described by David Chang. You can go for a Mulligan ring, as you can see here in this particular case, or you can go for a BX ring, which is also very, very easy. But more importantly, the take-home message is, an IFIS, better to be safe than sorry, because you can end up in a very serious problem, and this is a surgical strike which is likely to happen tomorrow. Thank you very much for the wonderful opportunity, the patient attention as well.
Thank you, Dr. Mohan Rajan. That's a very excellent compilation of all the things that you can expect in a floppy iris. So we have the next speaker, Dr. Bharti Kashyap. Yeah, come on to this. No, he's here. That was the second talk. Yeah.
Good
Dr.
morning, everyone.
Kashyap. Yeah.
My presentation is in the form of video. It has a voiceover. So I'm going to show 3 cases of posterior polar cataract. The first is with the femto technique. The second is with phaco. And third has a complication.
Posterior polar cataracts possess serious risk of PCR at any stage of the surgery. The incidence of posterior polar cataracts is more in younger patients compared to those in the middle age or elderly. Low flow, low pressure surgery is preferred in posterior
ठीक कर दिया
polar
आवाज.
cataracts. Care is taken that the chamber is underfilled and the eye is soft. Flax does have a major role in posterior polar cataract in preventing PCR. Since the laser cuts are in vertical and horizontal planes,
Hydrodelineation is done at multiple points, and you can see the ring, and it is separated epinucleus from nucleus. And now by low parameters are used, and the epinucleus is separated sideways, and the central part is not touched. So with the sweeping motion, all the sideways epinucleus is. Now you can see when I am doing this, the central plaque is also coming. इसमें आवाज नहीं आ रही। आप लोग कुछ कर रहे हैं? म्यूजिक आ रहा है? शुरू में आ रहा था।
No, I think if you can. Yeah, please. But I think you can finish the last case and you can explain it along. That's better. So you already have explained it. Voiceover will have the same thing, I think. And we always want to hear you rather than the voiceover.
Tackling posterior polar cataract.
We have Dr. Rajendra Kumar
Flax
Gupta
does
here.
have a major role in posterior polar cataract in preventing PCR. Since the laser cuts are in vertical and horizontal planes and they leave a very thin posterior epinuclear plate protecting the weaker central posterior capsule. Whether flax or fake, we have to consider certain major factors like hydrodelineation from the center to the periphery and no rotation, loosening the epinucleus from the periphery from all sides. Flax possess serious risk of PCR at any stage of the surgery. The incidence of posterior polar cataracts is more in younger patients compared to those in the middle age or elderly. Low flow, low pressure surgery is preferred in posterior polar cataracts. Care is taken that the chamber is underfilled and the eye is soft. Flax does have a major role in posterior polar cataract in preventing PCR. Since the laser cuts are in vertical and horizontal planes and they leave a very thin posterior epinuclear plate protecting the weaker central posterior capsule.
Can you sort it out and we can have Dr. Mohanta?
Whether flax or fake plaque, maintaining a central cushion, thus protecting the weak capsule. I am trying to chop the delineated and laser chopped nuclear fragments, taking care not to disturb the central part. We keep hydro or visco delineating and pull the nucleus and epinucleus from the periphery towards the center and eat it up. Visco is being pushed and the epinuclear plate is being phacoemulsified. Very low parameters are used and after the completion viscoelastic is injected. This is the second case where we have not done flax, so it is a little different. Rhexis is being completed. Attaining a perfectly sized capsular rhexis is extremely important as we need to take help of rhexis to achieve optic capture in the event of posterior capsular tear. You can now see the nucleus is separated from the epinucleus. When you eat up the peripheral part, you have to flip the epinuclear plate. Epinuclear plate and cortex is loosened from all sides and care has to be taken that only one side is not aspirated till the posterior capsular plaque, as it may end up opening the weak posterior capsule. Now, again, we eat up the central part if it is properly hydrodelineated and separated from the epinucleus. We have to keep patience. And in the last, all loosened epinuclear plate comes out very easily along with the central posterior plaque. We inject viscoelastic before coming out. This is the third case of posterior polar cataract, which is different, as usually in posterior polar cataracts the nucleus is soft, and this was a hard cataract. We have tried central to periphery hydrodelineation, whatever was possible. Now chopping is being done of the peripheral part and some of the central part, which is hydrodelineated by visco and saline. One has to be very patient and skillful with the chopper or Sinskey hook.
Now after the vitrectomy, anterior vitrectomy has been done, I am doing irrigation and
And look here, while doing the same, there is a PCR. Nucleus has not sunk in fully, so part of the nucleus is shelled out with the help of Sinskey hook into the anterior chamber.
and maintenance of low infusion pressure, you can see the IOP is less. Maintenance of the low infusion pressure apart from the low fluids is very important in managing the posterior polar cataract. Thank you. So I showed you 3 cases.
Phacoemulsification
Much of voiceover and the
We could get the concept.
is being used for the nucleus management after putting viscoelastic. All has not come, as some amount of cortical matter and nuclear matter has gone into the vitreous cavity. We are now using a vitrectomy cutter for removal of the rest of the nuclear fragments, epinucleus and cortical matter. Now irrigation and aspiration has become very easy.
Catch the epinucleus or the posterior capsule, which happened in this case. So
It happened in this case, but we have to remove the delineated epinucleus and all those parts first. And if the lollipop nucleus comes,
No. The technique has an inherent risk of damaging the posterior capsule in the periphery, mid-periphery, when you are trying to delineate the epinucleus and the nucleus with the phaco probe itself. So why not we just do only a perfect hydro delineation and delineate the nucleus with the fluid itself?
delineated it first. In all the cases I have done, first case was femto, and the second and third case was phaco. So I delineated it at multiple points.
No, this technique.
Hydro delineation I did.
No, how do you actually think that it is more advantageous than the routine conventional technique of posterior polar management?
It does help us, that's our way, but in one case it could not click.
Okay, anyway, sorry for all the technical glitches, but it was something to take home. Thank you very much.
But actually there is really a problem. So voice over videos will not go here because वो mismatch हो रहा है लोग का.
Now I call upon Dr. Pradeep Kumar Mahanta. Dr. Mahanta is a well-known a surgeon and a mentor for all of us.
I had first session.
उसमें भी कर होगा.
Now, if the speaker has a good voice, the voiceover won't come.
No, what she is saying that she also had a voice over. We could not play with in all the halls. In all the halls. Why we put voice over because sometimes video we are going to absorb. So if it is a voice over, it's good.
Sometimes so many surgeons
Yes. You miss some of the points. So we prefer voice over here. Here it is not the case.
Are you ready, Dr. Mahanta?
Shall I start?
Yes, sir, please.
Thanks to the organizers for this beautiful meeting. For hard cataracts, it depends on what technique, it depends on your skill and your intuition at that time, what you are going to do. If your intuition says that it's better to do SICS in a particular case, please go for SICS with a large wound. The patient, what matters to the patient is not phaco. What matters to the patient is vision. The patient should get good vision. So, here I am going to describe my technique for hard cataracts. Whenever the cataract is very hard, black, I do SICS or double SICS. But most of the time, I can manage with this technique. This is submarine chop technique. For submarine chop, after making the incisions and for better visibility, applying some visco over the cornea, we need to do a large rhexis. Size of the rhexis should not be less than 5.5 millimeter. I usually do a 5.75 to 6 millimeter rhexis. I usually use a utrata forceps. It depends on what you are habituated to. If you are using a needle all the time, it's fine. So with utrata forceps, I have done a large rhexis. And now hydrodissection is done at multiple points. Very small amounts of BSS is injected at multiple points. We cannot see the fluid wave. We can see the nucleus is lifting upward a bit. And then we mobilize the nucleus, apply visco again. In such cases, it is a better idea to do modified soft shell technique. You can use viscoat or chondroitin sulfate of any brand, and then underneath that you use HPMC. I usually manage with HPMC. And now the phaco needle goes in, some superficial lens matter is removed. I see the exposed part of the tip, it is little more than other routine cases. Now, no sculpting is done. Bury the tip just in front of the main incision, and it goes through the substance of the nucleus at a deeper plane under the surface, like a submarine goes underwater. That's why I have given the name submarine chop. Get a good crack. Don't do a lot of lateral separation. Come to the other side, rotating on 180 degree. And on the other side, I go to a deeper plane, hold on heminucleus with vacuum, and divide the nucleus into two heminuclei. In this case, on heminucleus is larger than the other, and I'm dividing this heminucleus into three parts. This is one, come to the bigger piece and divide this into two parts. And now this is done with very high ultrasonic energy. Ultrasonic energy is 80%, flow rate is 45 ml per minute, vacuum is 450 millimeter of mercury. The machine is not a very high-end machine, it's a Oatley Cataract 3 machine. And with this machine, I can manage most of the hard cataracts. And I have no financial interest, but most of the ophthalmologists cannot afford a Centurion. So with mid-range machine, we can manage hard cataracts. I come out managing half of the nucleus, inject more visco to protect the corneal endothelium, and now go again and I come to the smaller heminucleus, divide it into two parts and emulsify this. And this happens most of the time. Most of the time we can manage like this. But what if we cannot manage like this? What if we cannot crack the nucleus at on-go? This is, in this case, the submarine chop failed. After rhexis and hydrodissection, go with the phaco handpiece, and here you see that I cannot get a good hold. I needed to go much deeper plane, but this didn't happen in this case. So when the submarine chop fails, I make a deep crater at the center, almost 80% deep. And then I start dividing the nucleus into parts and emulsify the pieces. Rest of the cases as in other routine hard cataracts. So thank you very much. If you have any questions, we can discuss on that.
Very nice surgery. Excellent demonstration of how to deal with hard cataracts. Do you use any special viscoelastic to protect the endothelium?
Yes, I would say to the beginners to use modified soft shell technique like chondroitin sulfate first, and beneath the chondroitin sulfate you use HPMC, but I manage with HPMC in most of the cases.
So the point taken is have a slightly larger Lexus because you don't want to have any pull on the zooms, and also it gives you more space. And second thing is staining the capsule is very important because then it gives you a visibility throughout the surgery. And as far as your name of, what do you call it? Submarine chop. It looks exactly like the way I do it, but I didn't know, maybe I should call it snorkeling chop now, because you've already taken the name of submarine chop. It's really a fantastic surgery.
Thank you very much.
And also the place where you start in the center or you move towards the incision? Will
I
it make a
start
difference?
just in front of the main incision.
Main incision.
Just
So
in
that
front.
you go downwards towards the
go
center.
downward, then at a deeper plane horizontally.
Okay, right. And a sharp chopper is necessary?
No, not sharp chopper. It's a very small chopper, normal chopper. It's it's designed by me. It's just a modified Sinski hook. It is about 0.6 to 0.7 millimeter long.
And the tip is sharp?
Tip is not sharp. It's blank.
So
Well,
you also
sharp
kind of
chopper
feed it
really
when you're...
works.
It comes from periphery, so it's not
okay,
cutting
okay.
it.
So if you do a central chop, the sharp chopper really works because it cleaves your nucleus very nicely.
Yeah, but,
you should
yes,
really try it
that's-
because
that's a
but your
good technique,
technique
but
is a
this
little
is-
bit different. You go from the periphery, you do a peripheral chop.
And I go near the chopper at the periphery. Phaco needle goes near the
So
chopper.
the needle traverses most of the nucleus,
yeah.
not the other way.
Yeah, okay, right.
Thank you very much, Dr. Mohanta. That was a lot of things to take home. Any questions? If there are no more questions, I think we'll wind up this session. Thank you very much.